Welcome back, team. I'm your host, and today we're diving into a high-yield TMC prep masterclass focused on home oxygen and patient assessment. Let's get to it. Question 1. What is a key principle regarding home oxygen? Is it A, concentrators eliminate prescriptions, B, it's cosmetic, C, it's a prescription, or D, an over-the-counter supplement? The correct answer is C. Home oxygen is a prescription, not just a device. This is a fundamental medical treatment, not a convenience. Oxygen is considered a medication because it has specific indications, dosages, and delivery methods. It's prescribed for chronic or acute hypoxemia. It's vital for patients with COPD or pulmonary fibrosis. It improves tissue oxygenation, decreases heart workload, and boosts exercise tolerance. Remember, concentrators don't bypass medical necessity. It's definitely not cosmetic, and it's certainly not an over-the-counter supplement. Major TMC point: always educate patients on safety. No smoking, no open flames, and always have a backup system for power outages. In the ICU, we monitor for oxygen toxicity and worsening hypercapnia. Proper education prevents these emergencies before they start. Question 2. What is a sign of restlessness in a hypoxic patient? Is it a positive sign of improvement or something much more critical? The correct answer is B. Restlessness is a negative sign. It's often the very first indicator that your patient is deteriorating. The brain is highly sensitive to a lack of oxygen. Restlessness, agitation, and anxiety often appear before cyanosis or severe distress. Watch the progression. It starts with restlessness, then moves to confusion, lethargy, and eventually coma if not addressed immediately. If you see restlessness, immediately assess SpO2, respiratory rate, and breath sounds. Don't assume they are just waking up. TMC teaching point: restlessness equals hypoxemia until proven otherwise. Intervene early with oxygen or airway management. Following our VOCP hierarchy, we must address oxygenation and ventilation first when mental status changes. Speed is survival here. Question 3. What should a respiratory therapist do if a patient on home O2 is found smoking near the concentrator? The answer is C. You must educate about the fire hazard and remove it immediately. This is a life-threatening medical emergency. Oxygen itself doesn't burn, but it makes everything else burn violently. Smoking near oxygen is an absolute contraindication and a severe risk. Your priorities: remove the source, turn off oxygen if safe, educate the family, and document the incident immediately. Options like lethargy or hemodynamic effects don't apply here. This is purely about fire safety and hazard mitigation. TMC point: RTs are the front line for safety education. Prevent facial burns and explosions by reinforcing no smoking policies. Safe home care starts with you. Always double-check safety protocols with your patients during every visit. Question 4. What does a SpO2 of 85% indicate? Think about your normal ranges and what this means for tissue delivery. The answer is D. This indicates hypoxemia and compromised oxygenation. It's a critical value that requires immediate intervention. SpO2 measures the percentage of hemoglobin carrying oxygen. At 85%, oxygen delivery to vital organs like the heart and brain is severely impaired. Watch for compensatory signs like tachycardia, tachypnea, and accessory muscle use. Your patient is working hard to survive. Assess the airway, check the O2 device, and get an ABG. Treatments include supplemental oxygen, bronchodilators, or even BiPAP. TMC point: understand the causes. V/Q mismatch, shunts, or diffusion defects. Each requires a different clinical approach. 85% is never normal. Act fast, assess the cause, and restore oxygenation as part of the VOCP hierarchy. Question 5. What is the ideal I to E ratio for a patient with obstructive lung disease? This is a classic TMC favorite. The correct answer is A, 1 to 3 to 1 to 5. These patients need extra time to get the air out of their lungs. Patients with COPD or asthma have increased airway resistance. A longer expiratory time reduces air trapping and auto-PEEP. If expiration is too short, air gets trapped. Intrathoracic pressure rises, and you risk barotrauma or hypotension. Let them breathe out. To achieve this, use lower respiratory rates and higher inspiratory flow rates. Always monitor for incomplete exhalation on the waveforms. TMC point: Long I to E ratios are your primary tool for preventing autopeep in obstructive disease. It's all about that expiratory time. Remember, 1 to 2 is normal, but 1 to 3 to 1 to 5 is where you need to be for your obstructive patients to stay safe. Question 6. What should be reassessed after bronchial hygiene therapy? Think about how you measure success. The answer is D. You must check breath sounds, SpO2, work of breathing, and sputum production to see if the therapy worked. The goal is to mobilize retained secretions. Success looks like clearer breath sounds, improved SpO2, and productive coughing. Whether it's CPT, PEP therapy, or suctioning, failure to reassess means you might miss a deterioration or an ineffective treatment. Look for better aeration and reduced wheezing. If the work of breathing decreases, you've done your job well. TMC point. Always document the patient's response. Clinical reassessment is just as important as the therapy itself. Keep those lungs clear and always close the loop with a thorough reassessment. Your patients will thank you. Question 7. What do crackles heard at the end of inspiration suggest? This is a key diagnostic clue. The correct answer is D. Fluid in the alveoli. These popping sounds tell a very specific story about what's happening deep in the lungs. Late inspiratory crackles occur when collapsed or fluid-filled alveoli snap open. Think pulmonary edema, CHF, or pneumonia. When you hear these, check the chest x-ray and look for other signs of heart failure or edema. You might need diuretics or extra O2. Don't confuse them. Wheezes are about narrowing, raunchy are about secretions, but crackles are all about the alveoli. TMC point. Late crackles are more severe than early ones. They point directly to alveolar involvement and potential ARDS. Listen closely. Those end inspiratory sounds are your signal to look deeper into the patient's fluid status. Question 8. What is the term for a patient who responds only to deep pain and returns to unresponsiveness? The answer is B. Comatose. This represents a severe state of neurological dysfunction that we must address immediately. Coma can result from severe hypoxemia, hypercapnia, or brain injury. These patients cannot protect their own airway. The risk for aspiration and obstruction is extremely high. You need to rapidly assess the GCS and the need for intubation. Remember the progression: alert, lethargic, obtunded, stuporous, then comatose. Every step down is a step closer to crisis. TMC point. If they can't respond, they can't protect. Airway management is your top priority in the comatose patient. Stay alert to changes in mental status. It's often the loudest warning sign your patient is giving you. Final question. Question 9. What does a P/F ratio of 250 indicate? Break out those calculators, team. The answer is C. Moderate lung injury, or ARDS. A P/F ratio of 250 shows that oxygen transfer is significantly impaired. A normal ratio is over 400. 200 to 300 is mild, ARDS. 100 to 200 is moderate, and below 100 is severe. 250 is a clear warning sign. In ARDS, inflammation leaks fluid into the alveoli, causing severe V/Q mismatch and refractory hypoxemia. Oxygen just isn't getting through. Management focus. Lung protective ventilation with low tidal volumes and appropriate PEEP. In severe cases, we even prone the patient. TMC point. The P/F ratio is your gold standard for determining ARDS severity and guiding your ventilator strategy. Know your numbers. That wraps up our 9 questions. A P/F of 250 is a call to action. Are you ready to manage it? Great job today, Michael. Remember, the VOCP hierarchy is your map to saving lives. Study hard, stay sharp, and I'll see you in the next module. Keep pushing.